missed you and would like to. And Douglas, if you'd like to check your mic as well.
Yeah,
Hi.
hi, can you hear me okay?
Yes, Doug, thank you.
Hi, good afternoon.
Thank you.
Thank you, Paul. Sorry about that. And Mr. Bimani. Thank you. If you'd like to check your audio.
This is Manesh. Thank you.
Yes, thank you very much. Sounds good.
Perfect.
Good afternoon, everyone. This is the clerk with a courtesy announcement that this meeting is now being streamed live on the internet.
And good afternoon, Jackie. If we missed you for a mic check, Yvonne, would you like to check your audio?
Good afternoon.
Sounds good. Thank you.
Thank you.
If there's anyone that I've missed, if you'd like to check your audio at this time.
Yes, good afternoon. This is Eureka.
Thank you very much. Sounds good.
Good afternoon. This is Michael Giannaco.
Thank you, Michael. Sounds good. And good afternoon, Supervisor Simidian.
Good afternoon. How is our sound check?
Very good. Thank you. And
Thank you.
Dave is your clerk today.
Thank you very much.
Dave, can you hear me?
Recording in progress.
Yes, Dr. Smith, we can hear you. Thank you.
All right, I think we are ready to begin. Good afternoon, everyone. This is the Santa Clara County Health and Hospital Committee, and we are commencing our regularly scheduled 2 p.m. meeting. That begins, of course, with a call to order, and that requires a call of the roll by our clerk. Please call the roll and establish the presence of a quorum.
Good afternoon, Vice Chairperson Lee.
Present.
And Chairperson Simidian.
Here, thank you very
Thank you.
much. We have a quorum. That takes us to item number 2, which is public comment. Public comment is that portion of our agenda set aside for comment by members of the public on non-agendized items, but items that are properly within the jurisdiction of this committee. We will check with the clerk to see how many folks we have, if any.
We currently, I'm sorry, forgive the interruption, Mr. Chairperson.
Go right ahead.
We currently have one speaker in the queue.
All right, let's go ahead and take that one speaker and allocate 3 minutes for that one speaker. And we'll put out a last call for folks on public comment. Once this person is concluded, whoever is signed up by then will be in the queue, and we will then move through the queue. Go right ahead, whoever the first speaker is.
Thank you. Our first speaker is Ken Horowitz. I'm unmuting you. Please accept the unmute. You'll have 3 minutes to speak. The timer will start when you begin speaking.
Thank you. This is Dr. Ken Horowitz. I'm a member of the Santa Clara County Health Advisory Commission, and I want to invite the public to attend our Health Advisory Commission meeting this evening at 6:30. They can find the agenda as well as the meetings information if they go to the Santa Clara County website under meetings, and they will find that they can also Zoom in through a virtual teleconference. Tonight's discussion of the Health Advisory Commission will be to explore chronic disease. And our commission tonight has invited a consultant, Laura Uden, who has a background in working with different groups regarding coming up with solutions to a very complex problem, which is chronic disease. As you all are aware of, chronic disease affects at least one chronic disease affects more than 60% of adults, and more than 40% of adults have 2 or more chronic disease. And this includes diabetes, heart disease, cancer, etc. So I want to encourage people to participate, to call in, share their concerns about chronic disease. And we as a commission are an advisory group to the Board of Supervisors. And we hope during the next year to come up with some sort of report to the Board of Supervisors on some recommendations regarding management of chronic disease. So I appreciate your time and thank you for allowing me to speak for approximately 2 minutes. Have a great meeting.
Thank you very much, Dr. Horowitz. Let me check with the clerk, see if we have anyone else under public comment.
We have no other speakers, Mr. Chair.
Thank you very much. Then completes item number 2, and we'll move on to item number 3, which is to approve the consent calendar and any changes to the committee agenda. Our calendar does indicate that items 12 through 23 are recommended for consent. I believe we could add item number 10 to that as well if Supervisor Lee is amenable. Supervisor, can we get a motion to approve the consent calendar as contained in our published agenda in addition to item number 10?
Yes, thank you. I certainly move to approve the consent calendar. I do have comments to make on 17, but I'll go ahead and make the motion.
All right, motion by Lee, second by Simidian. We'll get comments from Supervisor Lee, and then we'll see if there are any members of the public who'd like to speak on any of the consent calendar items.
Thank you. Yeah, the comments on item 17, I would like to first thank the staff for the report. And I know that my staff has also been working with the team on clarifying a few issues regarding the LGBTQ trainings. And I'm going to leave that on consent, but would like to ask the off-agenda report to include the following issues. On the Q corner drop, would like to understand the number of clients that's currently being served, whether we are at capacity, what services may be lacking, and if we could also include information about after hours and how many individual clients are currently being served. In addition, I would like to also ask the data from the Avenia's contract on the LGBTQ older adult survey findings that will be going to the CSFC and also coming to HHC, and that this be added to the HHC work plan. Thank you.
Thank you. Let me see if the clerk can tell us, is anyone desiring to avail themselves of the opportunity to speak on this item?
We have no requests to speak, Mr. Chair.
All right, then we will call the roll on the consent calendar as amended.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Motion carries unanimously. Thank you. That takes us to item number 4, which is to consider recommendations relating to medical staff and allied health professionals. We have items 4A through E, which are to approve various privileges and appointments. And let me ask if we have a presentation on this item.
Hi, it's Yvonne Karanis. Good afternoon. I'm here to answer any questions if you have any regarding any of those items.
Thank you, Dr. Karanis. Let me go to Supervisor Lee, see if he has any questions, and if not, ask for a motion to approve.
No questions, and motion to approve.
Motion by Lee, second by Simidian. I will turn to the clerk and see if we have anyone who wishes to comment on these items.
We have no requests to speak on this item, Mr. Chair.
Then please call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Motion approved unanimously. Dr. Karanis, you were very persuasive productive, apparently. Thanks so much.
Thank you. Have a great afternoon.
You too. All right, that takes us to item number 5, which is to receive a report from the Facilities and Fleet Department. And this, of course, is in connection with the Child and Adolescent Psychiatric Facility and Behavioral Health Services Center. What would you like to share with us today, folks?
Good afternoon, Supervisors Committee and Supervisor Lee. You have the report, and I would just ask if you have any questions.
I do, and then after we address the issues that I raise, I will, of course, turn to Supervisor Lee, and then we'll go to the public if any members of the public would like to speak. And I think I should probably just start with Dr. Smith. Mr. Koenig, no offense intended, but what I'm noticing is I look back over the prior reports for the month of August this year. When I look at the little flow chart you've created, it indicates that construction will be complete in November of 23. When I look at September's report to this committee, it indicates construction would be completed in November of 2023. When I look at the October report, it indicates that construction would be completed in November of 2023. But when I look at the report for today's meeting, the flow chart indicates December of 2024, which is 13 months later. Dr. Smith, that is a 13-month difference from last month, the month before, and the month before that, notwithstanding the fact that I know in August and September, I asked if we were still on track, and the answer from all parties was yes, we were. What would you like to share with us that helps clarify where we are?
There are a couple of things going on. One issue is an issue that has been discussed in closed session with the board, so I won't go into it. But it has to do with performance. And the other issue is that the new, agency that used to be known as OSHPD, now with a different name, has informed us that the processing for our application has been delayed due to shortage of staff at the state level. So both cause anticipated delays of significance, and we're trying to give the committee and the board the best estimate that we can have of what effect that will have on the operations. So I think that's the best I can say in public.
Do you then anticipate that we really are delayed 13 months over the prior expectation?
I think to be prudent, I would say yes. There is the possibility of a change in that number based on what eventually happens at the state level and with our Excel, our contractor at risk. But I think it would be imprudent for me to promise anything less than December 24.
Okay. I am appalled, period. Supervisor Lee, anything you'd like to share?
Yeah, certainly. We are very much in need of the services provided by this facility. So any type of delay certainly is something that is very unfortunate. And I certainly would like to see if we could move those dates up. I know I see the OSHPD being delayed by, they say they have a 6-week delay behind schedule. But certainly by pushing it all the way from, it's from May, going to be in March 22 on some of the packages. I'm just trying to find out if there's any way we could move that sooner. But more importantly, I think, besides OSHPD, that 6-week delay is one thing, but 13 months is certainly much more significant. So if there's anything we could help smooth the process with the construction company, let's do it post haste so we could move forward ASAP. Thank you.
Dr. Smith, when do you think we might have a clearer idea of what the timeline looks like?
Sorry, I was having trouble with my mute button. I think we'll have a better idea in the December meeting.
All right, well, I will, of course, ask that we revisit this item in December. Supervisor Lee makes the point, which I think is compelling, that 6 weeks delay at Oshpot does not explain 13 months of delay or additional time for construction. So I think we need to wrap our arms around this as quickly as possible. And the reason that I expressed my disappointment so bluntly is because, as you know, Dr. Smith, this is the second time now that I have been told one thing only to discover that quite something else is the case. And it's hard at this point to have confidence in any of the information that's being provided in connection with the timeline for the project. So with that said, we will ask for a motion from Supervisor Lee to receive the report, which is the recommended action, and direct staff to come back to our December meeting with a revised and more considered timeline. Supervisor Lee, can I get a motion to that effect?
Yes, so moved. Yes, so moved.
I will second. Let's see if the clerk has anyone who'd like to speak on this item today.
We have no speakers on this item, Mr. Chair.
All right, thank you very much. That takes us to item number 6, which is the monthly COVID report. So,
Mr. Chair, pardon me for the interruption, sir. You have a motion in a second, but you did not take a vote on that item.
my apologies. Thank you. Call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye. Thank you for the assist, Mr. Clerk, and I can now report that the motion carried unanimously. That takes us to item number 6, which is our monthly COVID report.
Good afternoon, Chair Simidian and Vice Chair Lee. This is Dr. Sarah Cody. I don't have slides to share with you today, but I'll give you a brief verbal update and be delighted to answer any questions you may have. I would say overall, with the COVID pandemic, we're in something of a holding pattern at a high plateau. Cases are slowly drifting up, but not dramatically so. And our hospitalizations are a bit up, but overall quite manageable. And our focus continues to be, as it has been over almost the last year, to increase vaccination rates as quickly and comprehensively as we can. And of course, to always be ready operationally as soon as vaccine is approved for any new group. And as you know, just a bit over 2 weeks ago, Pfizer was approved for children ages 5 to 11. And that has been a focus of our work, in addition to making sure that boosters are available. So with regards to the kids 5 to 11, of course, the goal is to ensure ready access for every child in our county. And in order to do this, we have multiple strategies playing in parallel. Some are with partners such as healthcare providers. We've brought on a number of pediatric providers, community clinics, but the mainstay has been our county vaccination efforts, both in mass vac sites as well as smaller mobile vaccination sites. And with kids in particular, part of the strategy has been, again, this array of offerings where they may be more comfortable getting vaccinated by their provider, or they may be more comfortable getting vaccinated at their school. And schools have 2 main offerings available. One is partnerships with pharmacies, which many schools are taking advantage of, and that's been primarily facilitated by the County Office of Education. And the other is clinics offered at schools by the county's mobile vaccination team. And so far, overall, of the we've just begun to get data on the vaccination rates among 5 to 11s, and we're a little above 20% of the 5 to 11 population in the county vaccinated in the last 2 weeks. And there may be some data lag, so I suspect that that's a bit of a lag.
Interruption, Dr. Cody, just because you came off and on my soundtrack here. Was that 20% of the 5 to 11s?
About 20%. Yeah, I don't have a precise number, and I think that the data may lag a little bit, so it's probably a hair more.
Thank you. Go right ahead. I apologize.
With that's all, I mostly want to engage in conversation and answer any questions you may have. So I'll turn it back to you, Chair Submidian.
Thank you, Dr. Cody, and thank you and your team again for all the good work. Dr. Smith, I raised with you on Monday when we spoke a concern about the fact that our county had scheduled 97 visits to school sites in the months of November, December, involving, I believe, something like 50 individual school sites in order to provide vaccinations for school-age children, but that none of them, 0 of the 97 visits, were in schools in the 5th Supervisorial District, which of course is my home district that I represent. And I expressed my concern. I think the phrase I used was wholly unacceptable when we talked about this just yesterday at the Board of Supervisors meeting for a minute or two. I indicated then that I would want to use this opportunity to talk about it, since this is an agendized item today, and it was of course not on our agenda yesterday. And I guess, to try and express my concern a little bit more fully or a little bit more completely, what I would say is understanding the goal that Dr. Cody described a moment or two ago, which is to get the job done. I believe the phrase she used was quickly and comprehensively. That doesn't really square with the determination to go to 50 campuses and 97 visits and exclude the 400,000 folks, the 50,000 plus school-age kids in the 5th District. Because what that means is, if you're a low-income kid in District 5, you're out of luck. If you're a kid of color in District 5, you're out of luck. If you're just a kid from a middle-income family that pays its taxes to the county, you're out of luck. And the real irony here, in my view, is that because the criteria, as it has been explained to me, is heavily focused on vaccination rates in the surrounding area, if you're a kid who lives in an area where people exercise their sense of responsibility and got themselves vaccinated, then you're actually penalized for that fact, because the payoff for that good behavior by your friends, neighbors, classmates is that you're not an eligible school. So, that's a little tough to square with the fact that for a year and a half, we've been telling our county residents that we're all in this together. And I think it's very hard to take the view that we're all in this together when, 20% of the county has just been told you're out of luck. I know that there is some suggestion that, kids and their families can go elsewhere. But again, in the area that I represent, which is the area that I know best, that is not as easy as it sounds. I know anecdotally, and I have to say that's all I know, that folks who have private healthcare providers and the benefit of good insurance are telling me they can't make appointments with their healthcare providers in the northwest portions of the county that I represent. I know from my own experience that I called on a Monday, a Tuesday, and a Wednesday and was told that I could not make an appointment by the healthcare provider that I use. And I know from my own efforts to go online for the one site we have in the 5th District at Rainsdorf, that again, over a course of 3 days, appointments were not available. I have been told by your offices that things have improved, but again, today, when someone went online at noon, there were no appointments available. There were appointments available at other parts of the county, so somehow we're making those appointments available in other venues, but not in the North County. So if we're not going to the schools and private providers are still a challenge and our own limited efforts in the North County are not accessible, it really is very hard to tell folks, well, there are other options. And I suppose you can go to a pharmacy, but that hardly seems like an answer we want to give if we say we're here for the entire county. I want to just close, Dr. Smith, before asking you to comment by saying part of what's so troubling about this to me, and it reflects my listening very carefully to the briefings we've had over the last year and a half, are that what I've been told is that we will get better together in the sense that we can all work together to push that vaccination rate up as high as we possibly can, which will allow us to achieve herd immunity or something close to it. And yet, we're at a point where we are prioritizing schools apparently based on selecting locations where folks have not availed themselves of the vaccine, rather than saying, you know what, maybe some of our efforts should be focused on places where the take-up rate will be high. It seems to me if our goal is to push that total number up, that going to places where we know there will be a high take-up rate is part of a successful strategy. I was very supportive and remain supportive of our efforts to get areas that were initially characterized as underserved. But at this point, we've gone literally, you all have gone literally door to door. And as I say, if the goal is to get our vaccination numbers up, then maybe we need to think a little bit more about getting to people who want the vaccine rather than those who are, for whatever reason, resistant or hesitant. Dr. Smith, thoughts?
Yes, two issues that you brought up. One is the Rainsdorf appointment list, and we will get you a off agenda with details over the last month. But I think the problem has been that we have relatively few appointment opportunities because of the size of the operation, and the appointments that are freed up are used up pretty quickly. So we're trying to figure out how to fix that. And like I said, we'll get back to you off agenda. We realize it's a problem and we're trying to prioritize getting those appointments done. I'm not very happy about it, as you point out. And we will be working to fix it. In terms of the clinics, the school-based clinics that are operated by Mobile Vax, it was a wrong-headed decision on our part to look at the way that the distribution of need happened through zip codes, because obviously zip codes don't represent the concentration of need as effectively as do census tracts. And zip codes are large so that they overlap various areas. So an area that is very much in need and part of a zip code can be drowned out by other areas that are not so much in need. We saw this example happen with the state's equity proposal during vaccination, where all of this county was excluded from extra vaccine because of the use of zip code data. And we all know that that was incorrect and a bad thing to do. Sadly, we did the same thing, which was a wrong-headed decision on our part. And what ended up is that the priorities were focused on schools that were more concentrated in need, not recognizing the fact that there is need in District 5, but it's not quite as concentrated such that an entire zip code would show up as in need. So that's the explanation. It was a bad decision, and we're changing our process going forward and working to divert resources up to District 5 to try to correct that problem by starting more clinics in school-based areas in District 5.
Dr. Smith, I want to be very careful about language here. Thank you for the response. Thank you for the willingness to address the issue. You know, in the last sentence, I heard do more, but I also heard the word divert. And I want to be very clear. It is not my goal or intention or desire, nor would I countenance, quote, diverting attention from other schools or other districts. If this simply means we have to find a way to do more, then my expectation is that you all will find a way to do more. But I don't want this to be, I think we have done a really marvelous job as a county in understanding that we all have a public health department that has a responsibility for all of us, while still understanding that there are certain areas that where the need is greater. I think that's been, you know, one of the hallmarks of our good effort to date. So I just want to be very clear that we're not talking about diverting, we're talking about more. And to your point about zip codes, you know, I just asked my staff to grab a few schools literally within the last 24 hours, and they came back with Barron Park Elementary School, which I know well, it's in the Palo Alto Unified School District. 68% of the kids there are kids of color, and a quarter of them are eligible for free lunch and for English language learners. In Sunnyvale, the Vargas Elementary School, we've got a school that is 76% kids of color. A third of them are eligible for free lunch, and 45% of them are English language learners. And in the Castro Elementary School in Mountain View, so 3 different schools, 3 different cities. The Castro Elementary School, we've got 3/4 of the kids, 76% of the kids are eligible for free lunch. These are, you know, kids of low income. 69% of the kids there are English language learners. 94% of them are kids of color. And none of these kids and none of these schools were deemed eligible in the first screening tool. So I just want to sort of put some real lives and real kids in the middle of this conversation when we're talking about who is or isn't eligible. Dr. Smith, can I ask that we get a report off agenda on what you think you can get done in the rest of this year, November, December, since that's the dates we're talking about, by close of business a week from today?
Sure, we can do that. And let me address some of the issues that you raised. Number one, when I said divert, I didn't mean eliminating access to other parts of the county schools. What I'm talking about is diverting resources, which is different. It won't mean that anybody gets shorted, but like you say, it means more will be done. So I'm sorry I used that word. I mean, add. Second issue is I think that your rendition of the school districts is exactly an example of why it was a wrong-headed decision to use zip codes. We should have been looking at things like you just brought up, you know, free lunch needs, people of color, kids of color, other measures that would give us a better idea of what the need was. And so we will give you a report by next Wednesday about how we've been able to reschedule. Our goal is to make sure that we can provide services for hopefully at least 10 schools in District 5 in this first phase. And we will reassess our allocations in the second phase because this is just the beginning. We're not ending during this year. So I think, again, it was not a good process that was used. Nobody had ill intent, but using zip codes was a problem.
All right, thank you for that. Let me turn to Supervised Release, see if he's got comments or questions. And then I do have one or two more questions on other COVID-related matters, but I want to defer to my colleague, given the amount of time I have taken up on this piece of the conversation.
Thank you. I have a question, I guess, for Dr. Cody for what she's watching. We've been dealing with this Delta variant for a long time now, or for quite a while now, and looks like well over 98, 99% of our cases relate to the Delta variant. Has there been, I know there are other variants, but have there been any type of variants that we are looking at that might potentially be growing besides the Delta that we're fighting? And with the, yeah, so I just asked that question first.
Thanks for the question. At the moment, you're exactly right. The overwhelming number of variants are the Delta variant. It is successfully out-competing every other variant, and we're, I don't know, 98, 99% or something. So that really is what we're experiencing here.
Mm-hmm. Now, in terms of the case rates, I guess is somewhat disappointing that, we have been doing good. The booster shots are going up now, and our fully vaccinated is still increasing. And of course, now that with our 5 to 11-year-old being approved, these are all good numbers in terms of vaccination, right? But what's sad is that it looks like the infection rate and some of the other rates actually going more like, not going down, this plateau or starting to slowly inch up. And then the other thing that's disconcerting, I guess, would be looking at some of the other locations, right? So we are still having a pretty moderate fall right now, but clearly for the states in the middle of the United States or the northern states that's already experiencing the colder weather, you can see that those case rates has really dramatically picked up. So, and some of them actually have pretty decent vaccination rates as well. So I'm just throwing that question out as, and does it seem like we are fortunate now, but if given the temperature change, let's say the next 3-4 weeks, right, Thanksgiving and whatnot come in, should we be expecting that there will be another spike coming?
So of course, it's always impossible to predict what this virus is going to do. And as you noted, we were doing extremely well until COVID. I mean, the Delta sort of caught us by the collar and yanked us back. I sense that it would be unusual for us to come through the fall and winter and gathering season without a bump. So there's probably going to be some kind of a bump. I would be extraordinarily surprised if we experienced what we did last winter, because we have such high vaccination rates and they are quite protective. So even though some with the primary vaccination series have experienced breakthrough infections, very few with a primary vaccination series land in the hospital. And so, again, the vaccination rates that we have, I think, will protect us and are protecting us even with the Delta variant that's circulating. But I think that as you both have mentioned, the two important priorities now are, well, there's 3 important priorities. Folks who haven't received their primary vaccination, that they get them, so that we still have a group that's not been vaccinated. Those who are eligible for a booster, which is the vast majority of people who have been vaccinated, a booster can be quite protective and get people back up to a higher level of protection from infection. And finally, the vaccination of the 5 to 11s, which is the last group that's been made eligible. So we're doing all those things, and I, you know, as difficult as it is, I want to express my gratitude to our elected officials and to our county leadership, because our county still really stands out for the muscle that we've put behind the vaccination effort. I mean, when we look at you know, who's been vaccinated in the 5 to 11s, it's the county health system that is leading the pack far and away. I mean, it's an extraordinary effort that everyone has collectively put in, and I know it's still hard and we're still tearing our hair out, but we're actually doing an extraordinarily good job, and we have to keep at it. So my sense is that that COVID is not going to, we're going to be transitioning to a live with COVID strategy coming up.
Right. Yeah, I think you're absolutely right. That, which is, I guess, the bad news is that COVID is not going to go away anytime soon, and looks like it's something that we'll have to live with for a while, quite a long while. And with the waning effectiveness of some of the vaccines, that's why the booster is so important. And so I think one of the issues that we're dealing with a lot of it's really the complacency of people's thinking that, oh, great, look at those numbers, we're doing great now, so let's not wear masks and do a lot of the things we used to do, which, you know, of course, pre-COVID is okay, but I think that's the concern we have is complacency. One of those issues, you know, when it's cold outside, people are gathering, like you said, whether it's for Thanksgiving or other holiday events, with windows closed, and I think that's the big concern. So I just want to say, first of all, thank you so much, Dr. Cody. And last Friday and Saturday, I was get to visit the Emmanuel Baptist Church along with Congressman Ro Khanna, and to see, you know, so many parents and the kids all going to get their vaccination, the parents getting the booster shot while the kids is able to get eligible for the first shots. It's really great to see that, you know, the family actually doing this together, right? And many kids certainly is apprehensive. But as far as the Emmanuel Baptist Church, they have these life-size Wonder Woman and different action figures, including even Dr. Fauci out there. People are taking pictures next to it. I just want to say the creativity of all that is really commendable. I just want to thank you and thank the team. And then Dr. Fenstersheim was out there actually as well for these amazing folks who's working every day to get our residents vaccinated. So thank you, Dr. Cody. And that's all I have. Thank you.
Thank you, Supervisor Lee. I will just follow up with one or two questions. We were able to cover some of this in the rather wide-ranging conversation that ensued yesterday. Dr. Cody, as we've discussed previously, one of the questions that we get quite often is when will the masking requirement indoors go away? And you know, it may not be the most important question, but it's in my experience one of the most frequent ones. I have been telling folks based on prior briefings that I don't, and the criteria that you have publicly announced, that I don't have any reason to expect that requirement's going to go away prior to the end of this year. Is that an accurate interpretation of the information on hand and the criteria that's been established?
Yes, I think it is, because there are, along with other Bay Area counties, we adopted 3 criteria and told ourselves that we need to meet all 3 of them to feel like we can remove indoor masking as a prevention layer. And I'm happy to recite them if you're, if anyone needs pressure. Okay.
That's okay. I just wanted to make sure that there wasn't anything lost in the translation or in my understanding. But as I looked at them and as I've listened to you and your team in prior weeks and months, I just didn't see any way that translated into the masking requirement going away before sometime in the new year, we hope. And sounds like that's an accurate assessment. And not to turn you into the Grinch here, but does this mean that you would be discouraging holiday parties in the month of November, December, and early January from a public health standpoint? just, I think we probably ought to get that out there now if that's your assessment.
So I will give you guidance with as much clarity but nuance as I can. And that is to say that different than last year when I would have said, just don't gather. And if you do, stay outside. I think that people do need to see relatives and friends after 2 years, and we need to recognize that we have to balance those needs. But we really urge people to gather safely, which means to adopt as many prevention layers as you can. So for example, if everyone in the gathering is vaccinated and better yet boosted, that's going to be a very safe gathering, even if it's indoors without masks. If it's a gathering where there's someone that can't be vaccinated or is immunocompromised, then additional prevention layers you'd want to put in place, like make sure that everybody tests right before they gather inside, right? You can add testing as a layer of prevention. Most people don't want to have indoor masking or outdoor, cold dining for Thanksgiving. So those layers of ventilation outdoors and masking are probably not ones that people want to do for Thanksgiving. And so you're going to lean more on the vaccination test, and maybe make it a smaller gathering, reduce the probability that someone's going to infect others. But I think these are more toggling between prevention layers and understanding what everyone's own risk tolerance is. So the state has some pretty nice holiday gathering guidance out, and we're going to adapt it to Santa Clara County and have that out. So that'll be available for the public to help assist them.
Okay, well, nasal swabs may be the new holiday gift of the 2021 season, apparently. There you go. Thank you, Dr. Cody. That, all kidding aside, that really, I think, was sort of a helpful reminder of the risk reduction strategy that you have been emphasizing for a very long time now. And I think, if I had to summarize what you've told us repeatedly is, you can go about your business, just be smart about how you do it. So thank you for that. Dr. Cody, Dr. Smith, anything else you'd like to share at this time?
No, not from me.
Not for me. I just want to assure both of you that we are going to serve your communities. We are going to protect everyone who lives in the county. We are committed to doing that, and we thank you.
Thank you. All right. Let me just check with the clerk, see if we have anyone who wanted to comment on this item before we ask for a motion and a roll call.
We have no speakers on this item, Mr. Chair.
Thank you. Right, then we'll ask for a motion from Supervisor Lee on item number 6, which is to receive the report, but also to direct administration to provide the off-agenda information that was referenced in the conversation.
Yes, so moved.
Motion by Lee, second by Simidian. We'll ask the clerk to call a roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
Motion carries unanimously. Thank you all once again. That takes us to item number 7, which is the report on the sexual assault forensic exam program. And let me see who we're going to turn to for that today.
Chair Simidian, this is Paul Oren, CEO of Valley Medical Center. Kim Walker, the program director, will give you a brief update.
All right, thank you, Mr. Lorenz, and thank you, Ms. Walker. Go right ahead.
Good afternoon, thank you. In the interval following the October 22nd report to the Health and Hospital Committee, we've continued at the SAFE program to work on our service expansion and our safe response locations. So you have our detailed report, but there are a couple things I wanted to highlight in it. October was very busy for us. We provided 95 exams in October for patients 12 years and older. This is almost double what we usually see in a month. So it was quite busy. We provided 64 sexual assault exams and 31 intimate partner violence exams for non-fatal strangulation. With respect to our response locations, Santa Clara County sites, VMC remains the busiest, but it does meet the safe requirements. So our focus has been on Stanford, which I'm happy to report that the dedicated interim space at Stanford Healthcare was fully stocked and made ready and opened on October 24th. So we're responding in the new space that Stanford has generously provided, and we've been seeing patients there up to and including today. So we have good feedback from the advocates, the nurses, and staff that that's going well, but we continue to optimize that location and work with the design staff to configure what will ultimately be included in that space. We've also been preparing for the opening at St. Louis Hospital, and at that site, we've identified both dedicated exam room for the exams and a confidential interview space for patients to be in while they wait for safe response or for the advocates to arrive. And those all meet the recommendations for response facilities as well. Last, I'd like to say that we continue our education efforts. Stanford, we will be going to Vaden, the health center there on campus, to talk to the medical staff there and the ancillary staff there to discuss response and safe workflows so that they know how to get the students over to the hospital. So you have our report, but we're happy to answer any questions or any items you want to discuss.
Thank you. I do have a question or two, but first let me ask the clerk, do we have any speakers on this item?
We have no requests to speak on this item, Mr. Chair.
Thank you. Supervisor Lee, do you have questions?
Yes, thank you. I just want to follow up on the St. Louis. Now that we're expecting it to be operational by the end of 2021, that's great. Do we have a grand opening date on that, or we're going to at least just announce it? And
we will provide that information as soon as we have it. Both times that we wanted to open at St. Louis, COVID has kind of jumped ahead of us. So we want to make sure that as numbers start to increase again, we're being mindful, but we're in communication with them at all times to make sure that the workflows are not interfering with any of their operations. But we will announce that for sure when that opens.
thank you.
Thank you. Ms. Walker, let me just ask a couple of follow-up questions, but I want to confirm. Supervisor Lee, that covers your inquiries? Yes? Good. Thank you, sir. Ms. Walker, thank you to you and your team and your colleagues and folks who are involved in this. It sounds like you feel you've done as much or accomplished as much as you can on improving the intake process at the ER at Stanford. Am I reading that right?
I hesitate that we would ever say that we've fully met anything. We can always do better. So we're working on screening to make sure that patients who arrive are screened correctly so that we can get to respond to them or speak to them as quickly as possible. But we are always looking to optimize that. And Stanford has been a very generous and very collaborative partner in that. So that continues that work.
Thank you, because you anticipated my concern, which is that I'm hoping that once the very important facilities issue gets resolved, that the process issues don't suddenly fall off the table in terms of need to see whatever incremental progress we can make there. I hope we will make. You know, and obviously you know this work much better than any of us, but in terms of the quote education and outreach, is it your expectation that that will be continuing or ongoing rather than a sort of a one-time activity?
Yes, absolutely, because people move out of their jobs. We want to make sure that we continue to iterate that training so that it is always, the baseline knowledge is always the same. So yes, it will definitely for the university annually, if not sooner, and for the hospital annually, if not more frequently as well.
Thank you. That's reassuring as well. As far as we know, and I know that OSHPD or its successor by whatever name can be tough to pin down sometimes, but as far as we know, things are still on track for state review and approval of the necessary physical changes at the Stanford site? Yes, no, maybe?
That's going to be an Allison Kerr question, and I know she's on right now.
Yeah, sure.
Ms. Kerr,
I can answer that. Yes, Supervisor Sweeney. So what I can tell you is that our planning, design, and construction team is having a meeting with OSHPD next week to let them know about the plans so far, get their direction on certain things. The expectation for us at this moment is that we will submit those plans to OSHPD at the end of December, which means we've gone through full design of all of those plans, obviously, that we've done with Kim and our advocates, et cetera. So we're expecting to submit by the end of December. We obviously will stay on top of OSHPD, but we will be beholden to their timeline. But they certainly are aware of the urgency for which we would like this completed.
All right, thank you. And thank you again, Ms. Kerr. And then back to Ms. Walker. I just want to confirm that you're still feeling optimistic about the ability to open the South County facility before the end of the year, yes?
Yes.
And Ms. Walker, I know this is a hard question, and if there's no good answer, there's no good answer. But as we look at the disturbing increase in the number of cases that you all are obliged to respond to, do we know whether that's a function, or do we even have a informed assessment or intuition about whether that's a function of more assaults or greater awareness of the fact that there is a place for people to go in the aftermath of these assaults, or the fact that we've expanded to other locations, or greater outreach? What's your take on this phenomenon? And again, as I say, if it turns out we really don't know, fair enough.
I can't say that I know, but the fact that all of our response locations, including Santa Cruz, have all risen at the same rate makes me feel like it's maybe something else. Certainly the outreach and all of the response locations are helping. I think we've established previously that if we build it, they will come. So we know that that is a function that's in place, but the numbers are increasing even independent of that, it feels like.
All right, we're going to, as I recall, we're going to hear this item, we hope, for a wrap up for this phase of the work and the conversation in December, meaning one more meeting where we will endeavor to make sure that we're still on track for all of this. And I believe you're also going to be presenting, Ms. Walker, to our Women's Commission, yes?
Yes.
And that will be at their first meeting in December. And we are also expecting the Harvey Rose auditing team to weigh in with their thoughts about both what's been happening and what should happen in the future around that same time, yes?
Yes.
Okay. Mr. Lorenz, Ms. Walker, anybody else? I'm inclined to think that we need to stay on top of this, but that perhaps going to a twice yearly reporting to our Health and Hospital Committee for all of the sites might be the best path forward. Mr. Lorenz, does that seem both doable but also sufficient to the need?
We would be pleased to do that, and yes, it would be sufficient. If there are items for which we have to report to this committee sooner than later, we will do that.
Thank you. Ms. Walker?
Yes.
Okay. Supervisor Lee, does that sound like a good plan going forward to you before I call on you for other comments or questions?
Yes.
All right. I see your hand was up. Any other comments or questions?
Yeah, actually, I do. Looking at the report on page 3 or 4, we talk about some safe program activity for outreach continued throughout October and November. And one, they specifically identified Santa Clara University. We've heard some disturbing news earlier in the month about some incidents of some drug-facilitated sexual assaults occurred at Santa Clara University, like when school opened. I'm not sure, did you hear about those at all, Ms. Walker? And if that's the case, whether we have done any outreach to help connect those victims to the SAFE program?
I've heard about it, and I can't talk specifically about the cases, but certainly we work closely with Santa Clara. In fact, I have a presentation Thursday night with their student EMS responding, the response group there. So we'll be talking about basically what to look for and how to respond and how to connect to the SAFE program. Right.
Yeah, just want to make sure that's being done, and whether or not, if it becomes something would be necessary to be provided at the freshman orientation or school orientation when school starts, because apparently that's how it, or when it happened. The story we heard from the outside through third-hand sources. So I just want to make sure that that might be something that would be worthwhile to do for the future as well. Thank you.
And additionally, we reported at the board yesterday, there was the report that came in on the drug-facilitated sexual assault expansion to all of the hospitals. So
Good.
we are coordinating with that as well.
Great. All right. Thank you, Ms. Walker. And that's all I have.
Mr. Chair, you're on mute, sir.
A year and a half later, you'd think I'd have that down to a science by now. Just trying to confirm, Mr. Clerk, that we do not have anyone else who would like to speak on this item.
We have no requests to speak on this item, sir.
Thank you. All right, then I'll ask for a motion to receive the report from Supervisor Lee with direction to calendar this item twice a year after our December final report for 2021.
Yeah, so moved.
And I will second, and we'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank you.
All right. Motion carries unanimously, and we'll send folks off again with our thanks to all of you who have been working to get us to a better place. Much appreciated, truly. Take care. All right, that takes us to item number 8, CalAIM and whole person care and all kinds of complex and important stuff. Mr. Santiago, are we looking to you to lead us through this exercise?
Yes, good afternoon, Mr. Chair Simidian and Vice Chair Supervisor Lee. It's Michelle De La Calle, Director of the Office of System Integration, and myself that have a presentation. We'll walk you through a PowerPoint. I think it's, I appreciate the time and attention given the significance. Obviously, everybody rightfully so is thinking of COVID as the single highest top priority, but there's also CalAIM right around the corner for us. And I think it's important as our Health and Hospital Committee that we spend some diligence here in terms of reviewing what it means for us as well as the Medi-Cal population in our community. We have a PowerPoint. I think Michelle has that available. We can make that available on the screen to just walk you through it. If we could go to the next slide. And I think Supervisor Simidian, you made the point at the last meeting in terms of the importance of the Medi-Cal program. And I think it's good and important for the general public to understand that the Medi-Cal program, it is one of the most comprehensive benefits, if it's medically necessary or appropriate, that's available not just for the poor population in our communities, but also the disabled, children and families of low income, as well as a variety of other populations. And it's probably one of the most popular features of the Affordable Care Act, which is national health reform. And as you know, it's a prominent debate in terms of expanding the Medi-Cal program in other states, the remaining states, primarily in the south of the US, where they have refused to expand the benefits. Luckily, here in California, not only is it very comprehensive, but the governor, as well as the state legislature, has found it in their wisdom to expand the program and cover as many people as possible. There's 13 million covered under this program at the state. Here in our county, there's 400,000 plus covered as part of the Medi-Cal program. And as you can see here, the benefits in some cases are more comprehensive than what people find in the private and commercial markets. Significant, given the prominence of the issue here locally, is the mental health and substance abuse treatment services, including patient care for those services that are available for the Medi-Cal populations. And that is significant for us, not only because obviously it's a high priority for many of the families in our communities, but also because that's the county responsibility. We're responsible to provide the mental health and substance abuse treatment services for that population. But because we do have an extensive safety net, and our county, both your leadership as well as the county executive, has made health a priority, we actually have a very extensive and integrated healthcare safety net that provides all these services in very specific communities throughout the county. Next slide. CalAIM is what I make reference as Managed Care 3.0. It is a sweeping restructuring of the Medi-Cal managed care delivery system using a very specific section of the Social Security Act, which is normally called Section 1115 and 1915B waivers, to do some very specific things. What CalAIM is proposing at this point in time, beginning in January 2022, is to continue the mandatory enrollment of Medi-Cal populations under managed care. And it standardizes the benefits, rate setting, as well as some of the reporting data, particularly focused around access and quality. And we'll go into a little bit of detail around that. It also moves the population health management strategy to plans, to managed care plans, so that they can begin to address some of the social needs through rates and incentives that we, through pilots, have identified as being very cost effective, as well as improving the overall health of the populations. There is included under 1915B behavioral health payment reform, moving us to what's commonly referred as IGTs, which is intergovernmental transfer. We just change the way we get reimbursed for mental health services and substance abuse services. And then it seeks to integrate what it calls full integration plans, plans that managed care plans that will be taking responsibility for health, behavioral health, and dental care beginning in 2027. So it sets a target date in the future of 2027 for these full integration plans. It is beyond the traditional managed care in the sense that there are significant requirements of managed care plans for population health, risk management, and improving overall value. And there's very specific incentives outlined not only for managed care plans, but likely also for providers to improve the quality and performance. And if you recall, I had reported in previous meetings that over the last 10-year experience, based on the California Healthcare Foundation's report, there was a very mixed experience in terms of how managed care was actually improving or not improving quality and the performance in terms of the delivery of care. Moving on to the next. It's pretty important for us from a policy context to understand what CalAIM focuses on and what it's not, given the obviously priority of healthcare in our community. As you and your peers have indicated, universal care coverage is a high priority for us as a county. So we're always looking for opportunities to advance our goals. So I thought it would be important to show here what CalAIM focuses on and what it's not. And so on the left-hand column, you'll see that it seeks to improve value and improve quality, specifically requiring managed care plans to become certified as NCQA, which is the national standard for accreditation on quality for managed care plans, as well as other types of services. All Medi-Cal beneficiaries and high-risk beneficiaries will be eligible for enhanced care management, and we'll talk a little bit about that in terms of what that means, ECM, as well as specific community supports. As I indicated, it reforms the financing of behavioral health, and then makes duals, that is, people that are elderly or disabled that qualify for both Medicare and Medi-Cal as a mandatory enrolled population for managed care. What it's not single payer. So this is not necessarily health for all. It's very specific, categorically defined in terms of who are the eligible populations. And it seeks the authority to enroll them under managed care. So people don't have necessarily free choice in terms of where to go for their care. It also seeks to, it does not seek in any way to align a variety of different things that are happening at the state. For example, Cover California is still a separate initiative, as well as maintains certain specialty carve-outs. So it is a separate but equal kind of model where certain populations are carved out of the mandatory managed care enrollees. And therefore, we have to deal with the administrative cost of going through the process of determining what people are eligible for. Are they eligible for straight Medi-Cal or some Cover California, or are they eligible for specialty carve-outs? And that adds a layer of both cost and administrative complexity that inherently, quite frankly, it forces providers and others to go through an administrative process in terms of whether people qualify for them or not. And it's not the public option model, which has been discussed nationally in advancing some of the ACA initiatives. The next set of slides, Michelle will talk to you a little bit of our local experience related to the Whole Person Care Project.
Yes, thank you. So our Whole Person Care pilot is ending at the end of this year, and we are transitioning into a Whole Person Care initiative that includes some of those components of CalAIM that Renee just reflected on. Most importantly, the enhanced care management and community supports, which were formerly known as in lieu of services. So the first thing I want to say is that the Whole Person Care pilot has worked. We were able to enroll over 7,600 people into this pilot. Currently, we have over 2,000 enrolled, and 61% of those maintained engagement during the time of that enrollment. When you look at who was enrolled, these were very complicated and complex clients that had, in most cases, more than 50% were in one or more than one category here. So they were experiencing homelessness and had chronic medical conditions. They were justice involved and had mental illness or substance use disorders. So there were also several that had all of the above. So these were some of the most vulnerable folks in our community that we work to engage with and enroll and provide these wraparound services. And what we found was we did see progress in their health and well-being. We found them engaging with their care coordinators. And the next slide, I'm just going to show you some of the outcomes on high-cost, unplanned, emergency, and inpatient utilization. I want to make sure that it's really clear. This is not the only thing that's been happening in the last 6 years. So there may be other factors that go into this decrease in utilization. Yet we really tried to look specifically at that enrollment date and the time prior to the enrollment date and the time after. And we're pleased to see this because it appears that there are significant decreases in the unplanned emergency and inpatient utilization across our physical health and behavioral health acute services. So this has been consistent over time, looking at the date of enrollment as the center line. So this is not based on time, calendar time, it's based on time of enrollment, prior to enrollment, and post-enrollment. And those have been some of the measurable outcomes. The individuals that you hear from and the stories that we hear from our patients that we work with and our care coordinators across the system, it improves outcomes. It also improves trust in the health system. It improves our relationship with the folks in the community. And we've had a lot of opportunity to work with our community partners. Now, as we look at the pilot ending and the work continuing, it's really been incredibly important for us to partner with our internal organizations, so internally to the county organizations, working with our managed care plan partners to develop and share what learnings we can in trying to match that through to the CalAIM proposals as they move forward. We've been partnering with the state to determine who are those folks that will transition over to ECM and community supports, and really looking for those final details to work all of those pieces out operationally, but really knowing that this is the right thing to do for the individuals we're serving. It's the right thing to do for our community at large. We are currently digging into the gap that will remain and looking to our partners to fill that gap through additional waivers, through mid-year requests, and really just focusing on maintaining the work that has been successful through the pilot and assuring that we support our managed care plan partners, our internal partners in our county system. So working closely with Valley Health Plan, working closely with Office of Supportive Housing and others to really make sure that we understand where those gaps are and what we need to do to make sure that we have this matching and mapping to the CalAIM proposal. And I think that goes back to you, Renee.
If you could show the next slide, I think you have the outcome.
Oh yeah, I do have that slide. So these were 6 key areas that we found successful through our process. So these are the whole person care activities on the very left, and they map to CalAIM activities. When those CalAIM activities go live in the CalAIM mapping, and then some just comments that we need to look at. When we look at care coordination that we perform during whole person care, that maps to enhanced care management that will go live for the majority of our populations on January 1st. And those are that we're doing a lot of work to map those to the transition process. There's some new populations that are going to be starting on January 1st and additional populations that will roll out as we move through the CalAIM proposal. We do have one population that we've served through whole person care that is not quite mapped in CalAIM, and we're working very closely with our partners in the community as well as internally to provide those services to that population. Housing navigation is something that during whole person care we did as part of care coordination in CalAIM. It's going to be moved into a community support, and that goes live on January 1st. And we are working with our health plan partners and OSH and behavioral health and physical health to really figure out how we're gonna map those things and make sure we capture that valuable service. Housing tenancy, there's a discrepancy between Anthem and Family Health Plan and when they're going live with that, but we're working collaboratively with both to really make sure the transition is smooth and that in that transition where there is a gap that nobody loses service during that time. This sobering center was developed through a whole person care pilot. It is now transitioning to a community support that will go live on July 1st, 2022. And we are collaborating with Reentry Center, Jail Diversion, Behavioral Health to make sure that we maintain this valuable program. In the meantime, medical respite has been supported through the whole person care pilot. And is transitioning to a community support in July of 2022. This is supported and ran prior to the whole person care pilot. So we'll just be partnering with the ongoing program to make sure that we map it clearly to the community support and develop what gaps might be in to get it to qualify as such. Our peer respite program, which is a behavioral health focused respite program, it is not mapped currently in the CalAIM proposal, and we are working with BHP, Behavioral Health, to really try to make sure we maintain this valuable service for our community. And we are looking to find and advocate with the state and our health plans to get it mapped into CalAIM. Thanks.
Thank you, Michelle. And if I may, I want to give a special thanks to Michelle and her team. You may not know this, supervisors, but Michelle has been working full-time as part of the hospital command center structure to respond to COVID. Her team has been deployed as part of the response, but they yet have continued their duties and have been collaborating with our managed care plans to try as much as possible here a successful transition given the state plans around CalAIM. So thank you, Michelle and the team. Now, all this sounds good, and you probably say, well, that's a good thing. Let's just figure out how to actually do it for more people and as part of a standardized benefit. Well, this is the complicating part. And normally this is where the risks come in, which is how the payment is supposed to work. The managed care plans, which in our particular case, we're a 2-plan county. So we have Family Health Plan as the public local initiative. And then we have Anthem Blue Cross as the private. They're going to be receiving a general global capitation rate increase across all the membership. Because again, it's a standardized benefit. Theoretically, people that meet certain clinical criteria will qualify for the standardized benefit. And the way, generally speaking, the state is going to be paying the managed care plans is through a general increase in their capitation rate. Now, there is some variation, for example, so kids not necessarily get the same rates because generally kids are healthy versus adults. So there is some variation depending on different, what we call 8 code groups. But for the most part, it's a general cap rate increase. There will be a rate adjustment for the enhanced care management. And as you heard from Michelle, some elements of whole person care are part of the enhanced care management. Other elements are not. So that's going to be one of the other complications here. And then there's also going to be funding for the managed care plans for community supports. But these are not necessarily going to be standardized and required. These are going to be voluntary. So depending on both what the plans decide to do and what the state requires them to do, these would be voluntarily available to the population. It's not necessarily a right or an entitlement to the population to get community supports. What the state is doing is that it's allocating as part of the governor's budget, $1.5 billion over 2.5 years to link these benefits and services to quality and performance. We know from our experience that if it's done very well and targeted, that generally, yes, it leads to lower inpatient admissions. It leads to less emergency department, which is very costly, and therefore managed care plans theoretically would benefit in terms of savings. And so the state is saying, well, if you do these things and lay out incentives, then you can do even better. So now 1.5 billion over 2.5 years, if you do the math there, it's about 500 million a year. The Medi-Cal program total statewide, it's about $105 billion. So it might sound like a lot of money, but in theory, when you look at it and spread it across a population, spread it across all these managed care plans, is not a lot of money. But yet there's high expectations. And obviously there's the payment is linked to the quality and performance. There's also very prescriptive requirements related to not just tracking the expenditures, but also the metrics and reporting requirements. And I think this is where the tension comes into focus related to obviously providers and managed care plans, how we're supposed to be implementing these things at a local level. What we, last slide here, what we consider to be imperatives for us as a county, and you heard a little bit from Dr. Smith at the last meeting, we're negotiating as a single entity, as one county, because we believe that as one county, we see the consequences and the fact that if this is not successful, what the impacts will be on the individuals as well as us as county government. And Supervisor Simitian, I believe in your statements yesterday, you said the healthcare system does very little health, very little care. And of course, there's really not much of a system. And I think that's a big concern for us. We want to make sure that the failings of the healthcare system do not show up where we normally see them, which is in our behavioral health, in our emergency rooms, in our emergency psychiatric units, and obviously even in our jails or on the street homelessness, because quite frankly, we did things at the right time for the right patients at the right care, and we should be able to get the better outcomes and avoid those things. So that's very important for us, that what we've been able to build in terms of the data infrastructure and integration and aligning and building the compatibility between all these initiatives that you and the rest of the board members have invested in us, that we maintain those. And in fact, we build on those successes, and we leverage and scale it to more people. We want to make sure that we continue to have a very strong identification and assessment of these high-risk populations, that we coordinated with our community partners. And obviously, we implemented in collaboration with the managed care plans in the state of California. We have a lot at stake to make sure that this is successful. And then, of course, we want to spread the learnings that we've had from our successful projects, as well as these partnerships, and then mitigate and safeguard any kind of gains and potentially close any gaps in care that we still have, and eliminate or at least mitigate some of the risks due to the transition to managed care. That concludes our report. Obviously, our written report has a lot more detail, and both Michelle and I are available to you if you have any further questions.
Thank you very much. Let me first check in with our clerk, see if we have any members of the public who would like to comment.
We do currently have one speaker in the queue, Mr. Chair.
Let's hear from that speaker, and then we'll go to Supervisor Lee, and then I'll take the cleanup position if I may. Go to it, Mr. Clerk. Let's let that member of the public speak for up to 2 minutes, please.
The next speaker is Mike Rogers. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, this is Mike Rogers. I recently was appointed to the County Health Advisory Commission. Thank you very much for the presentation. I had a couple questions and a statement about something the Health Advisory Commission is working on. The first question is, within the context of the county health system and CalAIM and the whole person care, I wondered if you are using on the front end of that assessments for behavioral health, standardized assessments for behavioral health, as well as social determinants of health, because one, they can be a guide to more complex patients and their needs and referrals to other agencies, non-NGOs, other capabilities that might help with housing, other types of issues people have. But secondly, because they're generally reimbursable through Medicaid, CMS, Medicare, et cetera, at least at some level. And so I'm curious about that because I've worked with other community health systems in other parts of the country have leveraged both of those things as part of similar programs. Second part of it, what I wanted to talk about was just talk about that the Health Advisory Commission has taken into the work plan for 2021 and 2022 to investigate functional medicine, integrative medicine, integrated nutrition as approaches that might be useful in treating non-communicable diseases, which dominate the top 10 chronic, dominate health costs in the top 10 chronic conditions in the U.S. One interesting part of that was talking about quality-based reimbursements. Some aspects of functional medicine have been very successful with very stubborn diseases such as diabetes 2, pediatric diabetes, obesity, et cetera. So it's something to plug for you to pay attention to what we're doing on that and to maybe engage with us a little more. I know that Ken Horowitz talked to Mr. San Diego recently on that. So those are my inputs. Thanks for your time.
And that concludes our request to speak.
Thank you. Let me turn to Supervisor Lee, see if he has comments or questions.
Thank you, Chair. On the report, there's also the T2020 multi-year initiative launched back in 2018 related to whole person care pilot. Just trying to see, the report doesn't, this report today doesn't seem to talk about the T2020. How are these two related?
They're very much related, Supervisor. The advantage we had as a county, of course, is that we have the behavioral health department, as indicated by the public commentary. We also provide the services within the jails. We're also are doing public health as well as we have our own health plan. And T2020 was a transformational effort. One of the CLTs, it had a variety of CLT projects that you've heard about in the past from Dr. Smith that aligned all these different strategies so that we can build sustainability day one. We knew that waivers were projects. There were, in some cases, pilots, experiments. We wanted to make sure that we learn from things that were working and that we actually institutionalize those things. So whether it be behavioral health assessments that needed to be standardized across a variety of different programs, because remember, at the state of California, behavioral health is still a carve out, but quite frankly, on the ground, we understand that many of the populations suffer common conditions, multiple chronic conditions, and therefore some of these things, to the degree that we learn they're effective and they're cost effective, particularly, we want to implement them and we want to adopt them across the whole system. So we built a whole transformational process as part of that T2020. There's a much more comprehensive, detailed report about that, and could provide that at a future meeting. And then what we're doing right now is, in fact, looking at development of T2025, because the CLTs and the transformation effort continues. We need to advance those things. We want to advance our systemness, whether it be a navigation of our system or whether it be in terms of providing one standard of care, regardless of whether you're uninsured or insured. We want to make sure that these things are actually handled in the most optimum and peak performance in terms of our health system. So we're hoping to continue to learn and advance those transformational efforts post the negotiations with the managed care plans, and then obviously advancing our own work.
Okay, now on the slides that you provided, there's this issue regarding enhanced care management. It talks about the new population, none of which being children experiencing homelessness. And then down below, there's this thing called justice population starting 2023. Are those justice involved youth you talk about, or what does justice population stand for?
Yeah.
Oh, that would just reflect anybody who's been recently released from custody health services, released from jail.
Right. So from custody health, and those won't start until 2023, right? That's what the plan is.
They won't
Yes,
be, yeah. They won't be identified as a population of focus until 2023. Yet our pilot included some justice involved individuals, and that service will not have a gap. We'll continue that service because the focus will include those individuals as well.
So the pilot already started, but that you don't plan on having it fully implemented till 23?
Yeah, let me intercede here, Michelle. What happens, Supervisor, is the Medi-Cal population, once they're incarcerated, they lose Medi-Cal benefits.
Correct. That's a big problem. Yes.
So they're not eligible for any Medi-Cal benefits while they're in jails.
Right.
What the state of California is proposing is that once they're released from penal institutions, that they be enrolled in these very specific initiatives beginning that year, so that in fact we can reduce recidivism. Now, we know already on the ground that if we provide a continuity of care and the coordination of care, that will get good outcomes.
Right.
And part of the good outcomes is not just recidivism to the jails, but also obviously readmissions to hospital acute and patient care as well as ED, but it's more of a benefit issue for the state of California.
Okay, good. So this is something unique to our state that we have this. Not other states would have the same type of treatment, but we certainly identified it. That's why we're providing that.
Correct.
Okay, great. Thank you. At this point, would you say that first of all, these are very helpful slides. I want to appreciate getting that done. And now, what do you think is the greatest challenge to the CalAIM implementation at this point in your view?
Well, I think there's a couple things. One of them is even though we're collaborating with the managed care plans, we want to ensure that we get our fair rates. We want to make sure that we take full risk and full responsibility for these populations, because as a county, we're in the best position than anybody else here locally to provide housing, for example, to provide social supports beyond just the community supports that are going to be funded by the state. And then, of course, as you indicated, making sure if they do fall into jails, that we continue that care and coordinate that care across different departments as well as out in the community. So there are very strategic and operational advantages that we have as a county to make sure that we continue to negotiate in good faith with these managed care plans, but that we get the full payment, make sure that we get, along with that full payment, the risk and responsibility. We understand, the risk and responsibility comes with it, but we want to make sure that we don't get shortchanged in that regard, because we know, as we indicated, we know if we fail to do that, it's going to show up in the general fund departments. It's going to show up in our jails. It's going to show up in other places that are not getting reimbursed.
Good. Right. Thank you. That's all the question I have for now. Thanks.
Thank you. Ms. Delacalle, thank you. Mr. Santiago, thank you. Let me just ask if we can go back to the slides for a moment. There was a slide that showed the mapping comparisons. I think it was, I want to say slide 3 or 4, if I can remember back that far. Let's see if I have a let's just, yeah, right there. Thank you. Okay, 7. So I'm off by an order of magnitude. Ms. Delacalle, let me just ask the term of art for mapping. When we say something is or isn't mapped, what does that mean in layman's language?
For example, chronic conditions. In our whole person care pilot, we identified a population of focus of an individual who may have multiple chronic conditions as someone eligible for enrollment for care coordination in the whole person care pilot. When we move into CalAIM, that specific population of focus, an individual with only chronic medical conditions, would not map into the CalAIM larger scope of work moving into the future. So justice, the population justice touched, is mapped, meaning it is in the plan to go live in 2023. So when I say chronic conditions are not mapped, it means we have to figure out how to continue this service without the reimbursement of ECM as indicated in the plan of CalAIM, the state's plan.
So for example, on this page where it says peer respite, and then under CalAIM activity not mapped, to put that in slightly blunter language, is that a way of saying that while we may have thought peer respite had value, the state isn't prepared to fund it for us?
Yes, we do think there is a potential map, meaning we do think there is place for this that is very similar to medical respite, but it's more on a behavioral health, with a behavioral health focus. We do think we have the ability to continue to advocate for this to become one of the community supports in the future. But as it sits right now, we do not have confirmation from either the state or the health plans that they're going to consider this particular service a community support at this time. I do feel confident that the work is valuable, and I think we can show that, and I think we'll make progress there. Yet at this time, we don't have a clear CalAIM reimbursement platform for this particular service that we developed.
Got it. I'm just trying to get a rough order of magnitude, so don't over worry this one, but if I were to say how much of what we have been doing under whole person care is mapped or covered by CalAIM as it is envisioned, are we talking 20%, 90%, some ballpark?
I would say most of the work in the whole person care pilot does have a CalAIM counterpart.
And if we could go back to slide 3, because I think that stuck in my, for some reason, slide 3 or 4, because there was a comment made. Let's go to 3, please. One of these 2 slides, and I can't remember, it may have been you, Ms. Delacalle, who said that essentially the prior iteration before we get to 3.0 was deemed to have a sort of mixed results, if I'm remembering your comment correctly.
Yes.
Yes,
That was my comment, Supervisor. I think in prior reports, there was a 10-year study by the California Healthcare Foundation that looked at Medi-Cal managed care in the state of California and how they had been doing related to quality and access. And it gave very mixed marks. For the most part, quality stayed the same for the 10 years. There wasn't an improvement. And at least for two indicators, based on the available data. That's always, an issue here in terms of what's the available data. But based on their review and analysis of the available data at the state of California, even there were two measures for kids. And as you know, kids are not only very important for all of us, but relatively cost effective to take care of them. But at least on two indicators, California had lost ground.
So is it fair to say then that the Medi-Cal managed care experience of the state over the last decade was not all that we hoped it would be, and that the move towards CalAIM and Medi-Cal managed care 3.0 is an effort to do better, to grossly oversimplify a lot of work?
Yes, I think you could say that. I think the state took a look and said, okay, how can do better going forward? It's still a question whether basic managed care rates layered with incentives are actually going to produce a different result. That's still a question, but that's the approach that the state is taking at this point.
Let me just ask a question about whole person care. And let me start with you, Mr. Santiago and Ms. Delacalle, and then see if Dr. Smith wants to chime in as well. It seems to me like we've been talking about this for at least a decade. And I'm curious to know, in your experience, what is it that's made this so challenging in terms of our ability to get the state and national government to embrace it? I mean, it just.
Yeah, actually, the whole idea of whole person care, as indicated by Dr. Horowitz and others, this aspiration to provide integrated, holistic care that actually looks at all the dimensions of human life, not just the physical medical care, but also their social, emotional, and mental health and other dimensions of life in terms of holistically, has been around for centuries, quite frankly. Whole person care specifically came out of our county based on our experience here locally, that we proposed to do these pilots, and the state and federal government approved as part of the 2015 waiver, 1115 waiver. And over the last 4 or 5 years, we learned some very specific things. So if I can work, how I could actually improve the lives and outcomes for both payers, in this case, the state of California, as well as their county and managed care plans, at the same time provide resources to providers and patients themselves so that they actually live a better life and have better outcomes. So we know some of these things actually can work. We, under the leadership of Dr. Smith, we pretty much have adopted the initiative as something that we strive for to make sure that we provide comprehensive integrated care across all county departments. So we really believe in the value as well as this idea. And then the question becomes, as part of this transition and this way that the state is conceptualizing going forward, how do we actually safeguard the gains and, of course, continue to make improvements?
Got it. Ms. Delacaille, any other thoughts? It just feels like it's a conversation that we've been having for a very long time without getting a big, group hug from a lot of folks at higher levels.
I think one of our patients recently said the care coordination model and what they received was like a warm blanket wrapping around them. And I think from the feedback from individuals receiving these services and from the providers giving these services, we know that we're making improvements and that we're impacting lives in a positive way. I think it's difficult to quantify that and develop a clear return on investment that's clearly measurable for such a variety of needs that are met when you address an individual and base their care and their focus on our individual needs. And I would say that is very difficult to measure. And I think we are making progress towards that. And I think CalAIM and the state's commitment to this is evidence that we're moving in the right direction. I think we're going to continue to talk about this because there will be ongoing needs to meet this standard of care for the totality of the individuals that need it. And I would just say it's the right thing to do. I think I'm proud to be a part of it as we've made this progress. I'm dedicated to finding ways to show the power of the work and dedicated to supporting it moving forward. And I feel very fortunate to be sitting in this county where we have support from the board, support from leadership, and support from the county executive.
Thank you. That's a helpful, thank you both, helpful. Dr. Smith, if Bert Margolin were with us today, I'd be asking him the same question. I know he's off recovering, but Dr. Smith, any thoughts about why it's been so tough to get more traction on whole person care at other levels of government?
I'm a poor substitute for Bert. He would probably give you a more philosophical, policy-driven answer. I will just give you sort of the down and dirty. I think the healthcare system in the United States has been built upon, a financial pattern or reimbursement structure that rewards individual care providers by treating individual patients as pieces. So the cardiologist gets a lot of money for doing what they do, and the brain surgeon gets a lot of money for doing what they do, and most of the hospitals in the private sector set up to treat people as organ systems, a conglomeration of organ systems. So the concept of whole person care is really anathema to the way that our quote system is set up nationwide. So there's a lot of resistance to moving towards whole system care, because the whole thought behind whole system care is that you treat the individual as one individual rather than a sum of parts, and that you treat them more efficiently, more effectively, so the amount of money divvied up is lower. So you got me in a grumpy mood, so that's what I would say, follow the money.
No, thank you. Well, thank you. No, I think that plus the issue of metrics that was described is, put those two things together, certainly you can understand why there may have been some reticence along the way. All right, thank you. Supervisor Lee, a motion to receive the report would be timely at this point. Gratefully entertained.
Yes, certainly, I agree. I think the whole person care is something that seems so common sense. I don't know why the federal government is not doing it, just like you said, the supervisor chair. And I do think, I think money is just certainly one of the big drivers of this, but I think we're living in the right place, being in Santa Clara County in the state, and that's why we have these services that many places, unfortunately, is lacking. That being said, so moved on receiving this report. Thank you.
All right, motion to receive the report from Lee, second by Semidian. Clerk will call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Semidian.
Aye, motion carries unanimously. Thank you again, Ms. Delacaya, Mr. Santiago, Dr. Smith, and the team. Much appreciated. That takes us to item number 9, which is hospital integration and financial performance. And Mr. Lorenz, I believe we turn to you again. Yes.
Yes, thank you, Chair Simidian and Supervisor Lee. So obviously you have a detailed written report on the integration progress of O'Connor Hospital and St. Louis Regional Hospital into the system. I'm going to give just a very brief overview of the report, some takeaways, and then we'll turn back to you, Chair, for further questions. First of all, the request was to review our financials compared to the pro forma. And I think the point that is really important to be made here is that the County General Fund subsidy, otherwise known, and we've termed as the county investment, if you will, has remained steady since the acquisition of the two hospitals. And in the report, we speak of EBITDA, which is earnings before interest, depreciation, amortization. And we provided that analysis because the pro forma presented by A&M used EBITDA to show a financial performance and valuation. And in the report, we had to make adjustments to that so that we can compare year to year how we were progressing. And the EBITDA also shows that we have remained steady in terms of our financial performance. And this is even in light of the system, your healthcare system, responding to COVID over the past year and a half. So from a financial standpoint, your system has remained steady in terms of its financial performance in light of the significant demands that has been placed on it in terms of both inpatient acute care services, outpatient services, but also in our response to the community-wide effort in support of the county around COVID-19. The other important thing that people should walk away with in terms of the integration effort is that even in light of COVID-19, there has been significant progress in both our organizational integration, but also our clinical integration. And I think all you have to do is look at the numbers relative to the fact that your system has far exceeded the pro forma numbers in terms of the average patient days, the average daily census at each of the hospitals. O'Connor and St. Louis Hospital, for example, 37.5% and 35.7% respectively, improvement over where the hospitals were when we acquired them. Those are significant numbers. So even in light of COVID and where we're headed, there's been much success in providing additional access and services to the communities that we serve. The number is also reflected in the number of surgical cases that that your system is providing, emergency department visits. They're going to exceed our pre-COVID numbers. So clearly this investment that has remained steady financially has really served the community well. I think what I want to do is, first of all, acknowledge a few people that are joining me on this call. Dr. Fong Nguyen, our Chief Medical Officer, Jill Sproul, our Chief Nursing Officer. Of course, Dr. Manesh Bhamani, who is the hospital executive for O'Connor Hospital, and then Gloria Della Merced for St. Louis Regional Hospital. Also, the president of our medical staff, Dr. Yvonne Karanis. So all of us are here and available to respond to any specific questions you may have regarding our report.
All right, thank you very much. And let me see if we have speakers from the public by turning to the clerk and asking, is there anyone in the queue?
We have nobody requesting to speak on this item, sir.
All right, then we'll bring it back to the committee. And Mr. Lorenz and team, and feel free to advance the right person to respond, Mr. Lorenz. On figure 12, which is page 10 of 20, I'm hoping that someone can help me make my way through this chart just a little bit more easily, or with greater comprehension at least. If I go from fiscal year 19 to 20, rather, excuse me, fiscal year 19-20 to then 2021 to then 21-22 budgeted, Let's just walk line by line. Pro forma EBITDA is telling me what?
So that is the earnings before interest depreciation, and that's a standard metric for which is used in the finance industry to compare operations. So that number is what the A&M firm had projected in terms of our performance relative to the acquiring of the two hospitals for each of the 3 years noted below.
And then I assume the next line is not a trick line. It says actual EBITDA, which is what actually happened. Yes,
that is correct.
And what I'm scratching my head about, and I'm sure the pandemic has something to do with some of this, is 36 as compared to 22 in fiscal year 1920 is, roughly 1.5 times the pro forma estimate. But when I get to fiscal year 2021, 373 is 10 times the 37 pro forma estimate. And then when I get to the budgeted year, the 208 is roughly 4 times the pro forma. So I've got not just that they're different numbers, which I think is to be expected, but radically different multipliers of what was estimated in the pro forma, but what turned out to be actual. What's happening there?
So as a public system, your system receives supplemental funding. And many times the supplemental funding isn't received in the year in which we would anticipate. So you have prior year adjustments that come in to affect your financial performance in any given year. So in order to compare apples to apples from year to year, you have to make adjustments in the EBITDA in order to account for that. And so 2 adjustments were made: prior year revenues, as well as COVID-related expenses, in order to show from year to year whether or not the system, in fact, is performing financially, where you can actually, evaluate year to year how you're doing. And so that is the reason that we have the adjusted EBITDA after COVID-related activities, as well as prior year adjustments. And if you look at that number going across, where you show a net loss in the financials or net loss related EBITDA, you can see that it fairly remains steady. And it's all relative, but you go from 234 to 268 to 208, which we are projecting based on the current year budget. So it's a way to fairly compare from one year to the next. The typical measure that we use in county government regarding the enterprise is how much is from year to year is the general fund contributing to operations, and that is the county subsidy. So the only reason we provided the EBITDA is your board requested that we compare our performance to the pro forma that was issued when we first acquired the hospital. But in both situations, whether you look at adjusted EBITDA or county subsidy, you pretty much see the same trend. And I think the good news in all of this is if you look at the current year, as we come out of COVID, you are starting to see the system really take hold. And what I mean by that is in 2 ways. One, in terms of patient volumes. And just this month alone, I believe O'Connor Hospital hit its highest level in terms of patient volumes, both in terms of its patient days, but also emergency room, surgical volume. And the same would be said true for St. Louis Regional Hospital. So that's one. So that will affect our performance going forward in terms of volumes and meeting the needs of the community. But the second part of it is that financially, the revenues that will follow those volumes are also looking much more favorable than they have in prior year, given COVID and given our other challenges. From an operational standpoint, Supervisor, I think it's also important to note is that many of the initiatives that we had planned strategically to undertake to integrate the hospitals from a clinical standpoint are now just taking hold. We refer to them in the report, but I think going forward, you start to see also an upside in terms of our ability to continue to be innovative, increasing access to the latest technology in terms of healthcare. All of those would contribute to not only providing more access to care, but also improve our financial performance overall.
Thank you. Let me just ask then on the version of the report that I have, just to make sure we're working from the same documents here. Packet page 91, page 10 of 20, the county subsidy goes year to year to year from 212 to 234 to 220, yes?
That's correct.
And so your point is, notwithstanding these various challenges, the subsidy increase from 212 to 220 million is not that appreciable. Is that kind of a takeaway I'm supposed to?
Yes. And let me also put that into context. And I'm sure Dr. Smith could also jump in. Keep in mind, over the past 3 years, outside of COVID, your system has also absorbed as an enterprise increases in salary and benefit costs. So other costs associated with just not the resources coming to bear to provide those services, but also in terms of service supplies, et cetera. So even if, and as you well know, the cost of healthcare continues to go up. It's no different from our system. But even with those increases in costs, your system has been able to generate the revenue through its performance to maintain somewhat of a steady requirement in terms of a county investment.
Thank you. And if I could ask you to jump ahead to figure 15, which is page 12 of 20, packet page 93 in the complete packet. But again, it's figure 15, patient days and mix by hospital. And here I'm just trying to school myself a little bit while we have you with us. So I'm looking at the mix of Medi-Cal, Medicare, commercial, and long ago, Ms. Lorenz, you were kind enough to help school me, as you may recall, one day in front of the whiteboard about the importance of the payer mix to our ability to be financially solvent. So I am not at all surprised though that our Medi-Cal percentage of the mix is 38.6%, dwarfing other healthcare providers who don't have our same safety net role and responsibility. I'm just curious, looking at El Camino in the line below, 3.9% Medi-Cal, 13 plus in Medicare, 12.8, excuse me, under commercial. If I add all those up, I'm still under 30%. Where's the rest of the revenue coming from for a place like El Camino, if that represents just 30% of their payer mix?
Supervisor, I'm going to have to check with staff, but there probably is an error in those percentages as you go across, but I will confirm those numbers. But sure. Typically, El Camino is a Medicare prominent provider along with commercial, with a very low percentage of Medi-Cal as noted.
Yeah, and I mean, it's a similar question for other lines, and we can do this off agenda as a follow-up, but I really would just like to understand the payer mix in the industry a little bit better. LPCH, Lucille Packard Children's Hospital, 18% Medi-Cal, 0.2%, so less than 1% Medicare, which makes sense to me since it's a children's hospital, and then 17.3% commercial. Yeah. If I add all those up, we're looking at 35, 36%. I'm just wondering, who is the rest of the payer mix?
Yeah, I think the addition is horizontal. Yeah, the addition is horizontal. If you look at vertically, they don't add the way across. They actually add vertically.
Correct. Yeah,
well, no, I get that they add vertically, but if I go horizontally, I am learning that Lucille Packard Children's Hospital has 18% of its payer mix coming from Medi-Cal, I believe, and less than 1% from Medicare, and 17.3% from commercial. And I'm just asking what's not covered there.
Yeah, I can add that. This is not actually each hospital's percentage. What it is out of the entire Medi-Cal market in the county, how much each system is carrying for. So that's why the total adds up to 100% in the vertical, but not in the horizontal.
So what I'm looking at up vertically then, thank you, because I now I understand why someone was saying not horizontal, is that the VMC is picking up 38.6% of the total Medi-Cal population in our county, as opposed to Lucille Packard Children's Hospital picking up 18% of the total in our county. And that's why we get to the 100% at the bottom of the chart. Yes?
That's correct.
All right. Thank you. That'll teach me to ask. No. Thank you. I was really,
it's a little confusing.
Really appreciate. No, very helpful. Thank you.
And if you did look at it the other direction, we'd have to have another column to add it up so that you give a percentage of their actual patient days that are from different providers. So
okay,
we could correct
no.
that.
Totally different set of issues addressed once I'm going vertically instead of horizontally. So thank you. That's that fundamental flaw was really sending off in the wrong direction. Thank you for that. All right. I'll turn to Supervisor Lee now that I know to add top to bottom, not left to right, and we'll see what his comments and questions are.
Thank you, Chair. Yeah, thanks so much for the explanation. And I would like to go back to figure 12, if we may, on the EBITDA. The purchase of O'Connor and St. Louis, that happened around the 18-19 timeframe. So I'm trying to see is on the FY 19 to 20 numbers, the 220, 233, does that already include St. Louis and O'Connor, or this is before they're in the system?
So fiscal year 19-20 was the first full year of the integration.
Right.
We acquired the hospital in March of 2019. So this was the first full year in which we can show a comparison from year to year of our performance.
So before that, the one before 18 to 19 would not have it. What would be the, I mean, it's not on the table, but do you have a guesstimate number of our system, EBITDA, for before they come on board?
I can get that for you, Supervisor. What I can tell you is that the system, in terms of projecting out the latter March, April, May, and June, prorated what we would expect in terms of our cost. And keep in mind that also that first year we did not acquire the accounts receivable, so we had a lot of additional costs relative to the cash outlay, which is not reflected in an EBITDA. But I can get you the EBITDA for that first year, for that period of time.
Great. I guess the reason I'm asking a question, just to give you the context, is I'm trying to figure out, in terms of O'Connor, St. Louis, DePaul, their acquisition, has that increased or outlaid every year, or has it been pretty even compared before?
Actually, if you look at the numbers, the fact that we acquired O'Connor and St. Louis Hospital is beginning to show that they've actually helped bring down the overall cost to the county. I think if we did not have O'Connor and St. Louis, we potentially could have seen, and this is all hindsight, but based on what we know, much greater contribution required from the general fund.
Right.
And the reason I say that is that if you look at the numbers in terms of our volume, the vast majority of the increase that we're seeing in terms of patient volume is at O'Connor and St. Louis, because they have capacity. VMC at the time was at capacity, and it was very difficult for us to hold on and to manage the demand in terms of patient care.
Right.
So in fact, I would say that the contributions at O'Connor Hospital in St. Louis has contributed to the overall performance of the system.
Right. So I'm sorry. Go ahead, Dr. Smith.
Maybe I can just add a slightly different perspective. EBITDA is really, even though it talks about earnings, it's actually a way of assessing value or worth of a business, because the value or the worth of the business is related to how much you can collect in earnings.
Right.
Our county subsidy is not that. It's actually operational money, tells us how much general fund essentially we need to budget into the enterprise fund in order to balance. So county subsidy reflects cash flow really, and EBITDA reflects value. And what we've seen is that the value with the 3 hospitals has been stable, and the subsidy required for cash flow has been really stable. It would be better to have earlier years, 17, 18, and 18, 19. But I can tell you what showed up there was that the cash flow would have been a little bit negative, in the sense that it took us some cash to get the 2 new hospitals up and running at state-of-the-art function, because there was a lot of deferred maintenance and lots of investment we needed to do in personnel and operations. But once we made those cash investments, the value is maintained, and the cash flow is improving right now, so that what we will see when we go forward in the next 2 years is that the EBITDA will start going up and the cash flow subsidy will start going down.
Right. So do you see, not that we would care about the profitability, right? Like Verity would, but you see a day that just say O'Connor and Louise, if you separate them out as a line item, would you be able to say that we might actually be cash flow positive on these in future years?
I don't think we'll actually make it to positive, although it's certainly possible. I mean, there is theoretically enough difference in the patient mix that could happen. You know, the problem with being profitable in our line of business is that, you know, we take care of poor people and people who are underinsured. Even if they're not quote poor, they're not insured adequately to compete in the private sector with what's needed there. Right. So I doubt that we'll actually ever get to a point where the 2 hospitals are profitable when isolated, but it's certainly possible.
I mean, especially in light of the fact that we just doubled our PCAP eligibility, right? You know, I don't know if this is apples and oranges I'm talking about, but let's say we cover more people, they can afford to have this insurance. So therefore, if they enter our system, it would seem like more people will be able to be paying for the services being provided. And in theory, then we will get to a point clearly, you know, much better than now, right? And eventually, not that we want to quote make a profit is not a bad thing, but our goal, of course, is for providing good services throughout the county to everybody, right? So, but just in terms of the dollars and cents here, if just to know the fact that, you know, the purchase not only provided the services someone needed, it turns out that cash flow at the end of the day is actually going to be 0 or even positive. That certainly would be great news.
Yeah, you're right. And that points out the reality that our financial productivity in those 2 hospitals will depend upon more people becoming at least insured to some extent, whether it's PCAP, Covered California, Medi-Cal, Medicare, our coverage initiative. The only trick to keep in mind about that is that PCAP actually comes out of the county general fund, so that even though it won't be counted as county subsidy, because it'll be counted as a coverage product or an access product. It effectively is a little bit of a subsidy, but you're right. if you look at the two hospitals isolated away from VMC, there is the potential of being profitable.
Great. One other area, which is I'm going to the figure 9, which I find a little surprising, was that the ED visits actually dropped in 1920 and then 2021. But then suddenly, based on the estimate for 21-22, it's going to be increased quite a bit. Just generally, do you see a trend for reasons? Is it because of COVID, or is it because of delayed care due to COVID that more people are more sick when they come in?
Well, the decline during that period of time is directly related
to COVID.
Right. And the volumes are exponentially increasing as we go out.
Right.
A lot of it having to do with the delayed care. And then people once again feeling comfortable of returning to the hospital for care. And that is something that we're keeping a very close eye on. But that is in fact what we're faced with. And we're not just seeing it in our emergency department, but I can tell you that many of our outpatient services, particularly in specialty, surgical and medical specialties, the demand is far greater than what we had pre-COVID. And a lot of it is related to the backlog of patient care that we experienced because of COVID.
So Paul, besides the number being worse now that people have been delaying, do you see the severity? In other words, people get here sicker because they've been waited too long?
I'm going to actually turn that over to Dr. Fong Nguyen, who can speak from a clinical standpoint what we're seeing in the hospital. I think it's more appropriate for her to comment on that.
Thank you.
Supervisor, if you don't mind.
Sure, of course.
Thank you. Good afternoon, Supervisor. So yes, we are seeing patients who are coming into our system with more advanced progression of their condition. I think at the meeting regarding the long COVID, Dr. Angela Suarez shared the fact that a lot of the primary care physicians are seeing patients with diabetes and other chronic conditions that are progressing more aggressively than what would expected. For example, with diabetic patient with uncontrolled hemoglobin A1C. I think we're also seeing a lot of patients without appropriate, let's say, breast cancer screening that we're going to be working through the backlog of patients that have delayed care. So that absolutely similar to other systems, we are seeing the impact of delay screening and ongoing medical care.
Wow, thank you, Dr. Nguyen. That was a prediction. I was guessing, but I'm sad to say that was the case, obviously. And I guess the question is how we could work out the backlog and give people the confidence to let them know that hurry up, come on in if you have problems instead of keep waiting it out. So thank you very much.
Yeah, thank you.
Yep. Let's see.
Can I add one little
Please,
comment?
Yes.
I think the question you ask is so very important, and Fong's answer is very critical. Our patient population oftentimes has trouble with access to begin with for various reasons. Sometimes transportation, sometimes disability, sometimes youth, lots of challenges to begin with. Even on a great day, 5 years ago, you could go to the clinic and find out that there were people canceling their appointments simply because they couldn't get into the clinic in time, or they didn't have transportation or whatever it was. Adding COVID and the backlog of work to that really accentuates that problem. So it's really something we're very concerned about, the access issues, and we're going to need to change our strategy somewhat to try to improve that. But there is a large pent-up demand out there. If you read all the statistics, I'm not talking about our numbers because Fong knows better what's going on with us. But if you just look at the medical literature. Huge pent-up demand for lots of people, and particularly populations of color that were negatively impacted by COVID.
Yes, indeed. And yeah, no, that's certainly bad news. And I certainly would like to find out there are ways so we could do some outreach to our patients and making sure that they realize how important it is for them to come in and that it is quote unquote safe to come to our hospital systems, that that we have all the protocol to make it safe so they're not worried about catching COVID or something like that coming in, right? That was probably a reason why a lot of people delayed those care. On the transition of the of O'Connor in St. Louis, so this has been almost 3 years now, right? By March 2022. I'm wondering if there's a way we could get some type of a report or feedback from the staff from O'Connor and St. Louis regarding the transition.
We would be happy to kind of survey and get a sense from staff. And we did do those surveys, conduct those surveys early on. So we do have a baseline. Dr. Von Karanis, I think, would be an appropriate person to respond to how the medical staff at the 3 hospitals are working together and how they're viewing the integration. And I would like for Dr. Karanis just to comment from her perspective as being the president of the medical staff.
Thank you very much for the opportunity to speak. Yeah, I think this has been an incredible journey over the last 3 years. We have had a very collaborative effort across the enterprise. We have written a new set of bylaws, which was modified off of the old Santa Clara Valley Medical Center bylaws, but essentially is a completely new document. And that was created with participation with physician leadership from all 3 hospital sites, and was passed through the medical staff by vote with overwhelming support for that document. We've also continued to create enterprise policies for peer review, for other processes within our system that ensure a high quality standard of care across the enterprise. So we're all working at the same level together. And we continue this work through our rewrite of the rules, as well as all of those privileges that you see coming through each month for approval at the board to ensure that we have a uniform system. By having all of this in place, this will allow for more seamless integration of staff across the system to allow us to care for patients throughout the system to provide the highest level of care that we can. And I think that again, it's been a very collaborative process, and we've been working very hard to ensure that we are a unified medical staff.
Right. No, thank you, Dr. Karanis, for that great update. So if we could do a survey like Paul was mentioning and get back to us sometime in 2022 or maybe early in first quarter, certainly appreciate it, because I think it'll be helpful for us to have a view at that point. I think 3 years is certainly good enough time to see how the integration is going, if there's still some challenges left, but certainly from all the metrics that we're looking right now, financially and patient care and all the different departments we're looking at, clearly shows that things have been going quite well in light of the fact that we even have a pandemic on top of all that to make it easier, really, right? So I just want to say thank you for that, and I want to ask if that's something, Paul, you could provide by sometime first quarter 22. I really appreciate it.
Absolutely. Thank you, Supervisor.
All right. And that's all the question I have, Chair. Thank you.
Thank you. The only other thing I will add, Dr. Smith will recall this, Supervisor Lee, is when we were in the process of attempting to rescue the 2 hospitals by acquiring and integrating them into our system. While that was something I think our entire board was enthusiastic about, I made a point at the time of calling it a very big lift, and I kept trying to sort of establish for the record that this was not going to be a 3-month, 6-month, or 1-year challenge, that it would be with us for a while. And I think that has certainly proved to be the case, that it was an immense undertaking, there's still work to do to make that vision of an integrated system real. But I really did feel from day one that we should both acknowledge the importance of the mission, but also acknowledge the difficulty that we were about to wrestle with. And I think all of that is proven to be just so. So glad we did it, but not a small task. Thank you to all who've been part of it, from the individual employee to the top of the hierarchy here. Much appreciated. All right,
Supervisor, can I
please
jump in with that? You're absolutely right. I just want to put it further in context that, when private sector hospitals amalgamate or consolidate, it's not atypical for it to take at least 5 years for things to stabilize out, both operationally and financially. Sometimes they never stabilize. We had the example here many years ago of Stanford and UC San Francisco trying to consolidate. It failed because of a number of cultural issues and finance issues. So when the board chose to purchase these two hospitals, you're absolutely correct. You told us it was going to take some time. It was a big lift. We were thinking at least 5 years before we're back to any stable pattern. And I think today you have evidence that within 3 years, we have good results and we're stable, which is not to say we're done. We still have a lot of work to do, but I think your prediction was correct, and we're making it work faster than would have been expected.
Yeah, the prediction I did not make, could have and should have, well, couldn't have, but should have perhaps made, is probably not wisest to acquire two hospitals right before a pandemic. But that just sort of landed on us. And again, it's to the credit of the organization, as Mr. Lorenz referenced in his presentation, that people said, okay, we'll work our way through that as well as an additional challenge during the process of the integration effort. I do see Mr. Santiago with a raised hand, so let me see if he has a further comment on this topic.
Oh, no, absolutely. I was going to emphasize, obviously, our clinical and operational team had done wonderfully in the acquisition of this hospitals, but also as a board, you ought to be recognized and having the strategic foresight, because imagine if those hospitals would have gone bankrupt and closed. What would have meant for those communities, given COVID, given the mass shooting in Gilroy. So when you think about it in terms of not only the positive direction that both clinically and operationally and financially that we're headed, but also the failure of, for example, a county of Santa Clara not stepping in and saving and actually not only providing jobs, but also providing the care and the services necessary, not knowing that there was going to be a COVID pandemic, and obviously not knowing that there was going to be a shooting in Gilroy. But the fact that those intangibles were able to be there, were able to provide the care and services that was so much needed for the residents in those communities.
All right, thank you very much. Then with that, I will ask Supervisor Lee for a motion to receive the report with direction to provide the, I'll call it current integration assessment, for lack of a less fancy title, Supervisor Lee, if that's okay.
Yes, so moved. And I actually would like to get the beta number of early years. So like 16, 17, all the way to 19, 20. I think that could be helpful for earlier comparisons as well. Thank you.
All right. Is that a number, Mr. Lorenz or Dr. Smith, that is relatively easy to provide our board?
It is a number that we can pull together and provide.
All right. Just wanted to make sure we were clear about how big a lift that was or wasn't. Thank you. I will second the motion. We'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye.
Thank you.
Thank you. Motion carries unanimously. Takes us to item number 10, but that was on added to consent, which would takes us to the last item for today's agenda, which is the item number 11, and that is the director's report. And Mr. Santiago, can we look to you to guide us through this?
Yes, and if you don't mind, Mr. Chair, in the interest of time, what we could do is we could go directly right into the departmental reports, beginning with public health.
Sure. And public health, we have heard from on COVID matters. Is there anything in addition to public health's COVID related report?
I presume not, I guess. We'll move right along.
No, that's all right. I'll channel Dr. Cody then and say, remember your flu shots. So that'll be my.
Public health is struggling with the mute button, and I have nothing further. And yes, on the flu shot. Thank you, Supervisor.
I listen to you every year on that one, and always with good result. Thank you, Dr. Cody. All right, that takes us to the next item on the agenda, which is a report from the CEO of Valley Medical Center. We've covered a lot of ground there. Mr. Lorenz, anything else?
No, not at this time.
All right. And Supervisor Lee, I'll just keep my eye on your square here. And if I see a raised hand, I'll call on you for comments or questions. How about behavioral health, whom we've not heard much from today?
Hi, good afternoon, Chair Simidian and Supervisor Lee. Sherry Terrell with Behavioral Health Services Department. You have our written report as well as a submittal of additional information related to fentanyl. So nothing else to add verbally, but open to any questions you may have.
All right. And I'll just say thanks again. All right. Anything from Valley Health Plan then?
Thank you, Supervisor Simidian and Supervisor Lee. Nothing really more to add other than our report. We are working hard now with the approval of PCAP to 400% of FPL to ensure that our decision tools reflect that change in an increased FPL level, and all of the other operations are streamlined to ensure that residents of the county who qualify for PCAP can be enrolled seamlessly and easily. We are working on Region 9 and building our provider network there for covered California. And we continue to improve our operations and our provider network.
Thank you very much. That takes us to, oops, there's that hand raised by Supervisor Lee. Forgive me if I missed it earlier. Supervisor Lee.
No worries. Yeah, so it's exactly on this. Thank you so much. Now that we have approved the PCAP expansions on Tuesday, I just want to ensure that there's going to be a robust outreach right to the community about the PCAP and other program reference in Renee's report, the healthcare access program. Knowing that SSA and eligibility workers play an important role of going out to the community, providing outreach and helping community members enroll in a variety of these government programs. I would like to request that Renee and the Valley Health Plan meet with SSA and about PCAP and the healthcare access program outreach strategies for the SSA staff, and provide a report for next month's HXC's meeting in December, especially for the population that will benefit from the PCAP expansion between the 200 and 400% FPL. And I would like to make sure that eligibility workers are going out to the community and clinics to share about the PCAP as well as the healthcare access program, and get these applications going for those who would qualify. Would that work there, Renee?
Yes, Supervisor. Through the chair, we definitely would, and I'll work closely with Laura and Bob Benecochi at SSA to report back.
Great, thank you.
Thank you.
All right, thank you for that. That takes us to F11F, which is the EMS agency. Ms. Lowther, do we have you somewhere here in the mix?
You do. Good afternoon, Supervisor Smidian. You have our report before you. Compliance has been very good. September, October was very, very busy, both for the field and for the hospitals. You have our domestic violence report, which you can see our abuse policy is out for public comment. Our third quarter data shows a decrease in statistics, and I'm here for any questions, and Dr. Miller is here as well.
Thank you. And
Jackie,
yes, sir.
can you maybe give the committee a bit of an update about our preparation related to the Kaiser strike? How
Yes,
it will
sir.
affect our
Um,
emergency system?
Yes, sir. The strike is still planned. They did come to resolution as far as the pharmacy is concerned on early morning Monday. We have mitigation strategies. The SEIU is planning on Thursday at 7 a.m. till 7 a.m. on Friday the 19th. And CNA is planning sympathy. Both of these are sympathy strikes for the engineers who have been on strike for the last 2 months. Our mitigation strategies is we have been working diligently with the hospital, COOs, CNEs, all week with the California hospital. For us, we have them currently on stroke and STEMI bypass, both hospitals. And beginning tomorrow morning at 7 a.m., both hospitals will be going on internal disaster as their SEIU employees, which also comprises laboratory, X-ray, CT, may or may not be there. They're scheduled to be on strike. So those services won't be available. They have engaged a private ambulance to be on standby for any walk-ups that may need to be transferred to other facilities. They have tried to just, impact their current inpatient patients to other facilities, is why we've been engaging with all the other facilities. They too are almost at capacity. It has been a true engagement of everyone to try and do their best. Stanford, VMC, all of them are almost at capacity. So that is what we're doing to open everything back up early on Saturday morning. And go back to business as usual. We have a duty chief on call 24/7. He has a backup plan as well if we need to place someone at county communications that can do hospital routing if that becomes necessary, to ensure that one hospital is not overburdened with transports. Our county ambulance system has placed additional ambulances on the road for the next couple of days, just in case any hospital is overburdened. And we do anticipate maybe extended wall times over the next couple of days. Questions on that?
Let me go to Supervisor Lee because his hand is up. But before I do that, I'll just say thank you for the chart with the percentage of on-time first responder compliance. You know, that's data that I'm always going to be taking a look at after all these years. Nice to see the numbers all well in excess of 90% as they should be. And Ms. Lowther, do I gather that the increase in the number of ambulance transports reflects a growing comfort or trust on the part of the public that they can call for help when they need it, notwithstanding the pandemic? Is that what we're experiencing?
It seems to be. I can't say that for certain, but the numbers are now higher than they were in 2019. Not a great deal, but the hospitals are reporting that the patients are also sicker. And those numbers definitely reflect a comfort in calling 911.
All right, thank you for that. Supervisor Lee, thank you for your patience. Go right ahead.
Yes. So first of all, thanks so much, Jackie, for the really good preparation that you mentioned for the next 2-3 days, given the potential strike impact from Kaiser. I just want to commend the staff for putting that together. and please do whatever it takes to make sure that if there's a overburden so I guess the idea would be, let's say if this gets a bit out of hand with too many people, so that O'Connor, they will be then moved to VMC. Is that type of balancing work that you expect would happen?
Yes. Fortunately, they are on opposite sides of town.
Right.
However, both of them have been receiving, both Kaiser hospitals together receive about 25 patients a day on a normal business day. And to take those, that's 100 additional patients for the other hospitals during this 48-hour period. And so we anticipate that both O'Connor, VMC, and even St. Louise may definitely feel the impact. Kaiser San Jose is definitely close to Good Samaritan and regional. Right. However, those stroke patients and STEMI very well may find their way to VMC and definitely O'Connor from both Kaiser Santa Clara and Kaiser San Jose as well. So we'll be watching. Dr. Miller and I monitor as well, and the duty chief will definitely be monitoring 24 hours a day. It's the same person both days.
Great. No, thank you. Thank you for that. That's really, really helpful. Separately, on the report on the domestic violence, on the disposition on those, one of the highest percentages, or what they call AMA, right, against medical advice, form people basically just says, no, I don't want to, basically they're saying I don't want to go to be transported away from the scene, correct?
Right.
Right. When we ask those questions to offer that, are they separated from the alleged abuser so that they feel the safety and privacy to make that decision?
Yes, sir. They make every effort to do whatever they can. We've had great results, and we did training this year, added strangulation to the training, have had excellent results with the compassion and caring from the medics, and even a case where the medic was able to ascertain what had happened when it wasn't disclosed to the police officer. So it's been a great training and great results of care and compassion by some of the medics. So they make every effort to get them in the back of the ambulance. And as you see, some of them choose not to go to the hospital, but they make every effort to try and encourage them to get assistance.
Right. Well, hospital, and also the fact that they will have a safe place to stay and not to report live back in the abuse situation. Okay. Thank you very much for reporting. That's all I have.
You're welcome.
Thank you, Supervisor Lee. And let me then say thank you to Ms. Lather and her team and move us on to custody health. Dr. Day.
Yes, good afternoon, supervisors. You do have my monthly report, and if there's no questions on that, I could answer any questions you may have around our current COVID activities.
Let me turn to Supervisor Lee.
Yes, really interested to hear about the outbreak and how we are dealing with them. Thank you.
Yes, we've had a recent outbreak. As you know, we have about 147 patients today that are COVID positive. What we're finding that of those 147, 66 are fully vaccinated. Another 6 are partially vaccinated. And then we have 75% that have been unvaccinated. We do have 5 patients that are in the hospital right now. And of those 5 patients, 3 of those were fully vaccinated and another 2 were unvaccinated. And so we are running our clinics. We have clinics that run 3 days a week for COVID vaccinations. We are rounding on every patient to offer the vaccination. As of today, with 2,485 census, 1,352 of our patients, or 55%, are fully vaccinated. Another 109 or 4.4% are partially vaccinated. And then we have 969 that we are continuing to round on and offer vaccinations. And so that's about 41%. And again, these vaccination rates are variable because we have patients that are leaving fully vaccinated and others that are coming in. And so other patients that have left fully vaccinated are 1,236. We are providing testing and testing surveillance and asymptomatic testing on a regular basis. And I will mention that all of these patients that are COVID positive, as well as those that are high risk exposed, we are doing testing on day 0, day 4, day 8, and day 10. So we're continuing to just watch over those patients. We're doing vitals and checking on them twice a day. So that is a huge sort of lift for our nursing staff. We have about 620 patients right now that are high risk, quarantined and are isolated and exposed. And so those are the numbers as far as our staff are concerned. All of the healthcare staff that are working behind the perimeter face to face are 100% vaccinated. And so we have just sent out a dual memo, actually it's a triple memo between, we sent out a memo just recently today between Custody Bureau, Custody Health, and Probation to remind our staff around the universal precautions of wearing masking in those high-risk areas, as well as the surgical mask every day, and also encouraging booster shots. And so we're encouraging our staff to get the booster shots. And we also have booster clinics here for those high-risk patients, and we're offering those across the board. Part of the, with the booster shots, as you know, well, you may not know, but we need to build a workflow in our health record, because originally we just had the, the workflow for 2 shots, but now with the booster and that 3rd shot, we need to be able to build that workflow that we're working on currently so that we can capture this information in the health record. So, are there any other questions?
Yes. May I, Chair?
Go ahead, Supervisor.
Thank you, Dr. Day. So the first question I have is, let's talk about those who are vaccinated first. I believe a lot of the patients did receive the Johnson & Johnson vaccine being one and done, right? And I believe quite a few has been given. Has there been any outreach being given to those who received the Johnson & Johnson vaccine to tell them that they really need to get a booster ASAP?
Absolutely. And as you know, we first started with the Johnson & Johnson. We started, all vaccinations, and that was several months ago with Johnson & Johnson, and then it was pulled. And so now when we vaccinate the patients, they have a choice. They could either get Johnson & Johnson, Moderna, or Pfizer. And so the numbers that we started with Johnson & Johnson, a lot of those patients have since been released. But the patients now with the booster, they do have the choice. We're encouraging Moderna. Moderna seems to have a better efficacy. And so the life shelf of the Johnson & Johnson, we're finding is about 2 months. And so the patients can choose. We're offering Moderna and Pfizer for those vaccination boosters.
For boosters. So I don't know if you've been able to identify, I mean, we have the record, I assume, who's got the Johnson & Johnson to advise them to get that the booster, because as we know, the efficacy of Johnson & Johnson is so low, right, especially with time passing. So that's one. Now, for the there's 959 that has declined the vaccine, and you said that was about 41%, right?
969. 996, I'm sorry.
I'm sorry, 996, okay. So for those who declined, I don't know what outreach, what effort have you tried, to try to get them to change their mind, shall we say?
Supervisor, I have a dedicated cohort of nurses, and this is all they do. And so what they're doing is they're rounding those patients every day and offering. And if they decline, we're asking again. And so it's not just the one time. And for instance, of those 996, just in the last month, they have been at least asked 3 times. And so they're always asked if they would like to get the vaccination. It's not a one-time offer. And so the dedicated nursing staff also are doing education. And so part of what they do is they surveil, they do education, they provide handouts and supplemental information. And now we also have a booster campaign that they're offering education on the boosters and handing out flyers. The flyers that we're using for both the vaccinations and the booster, we have those in 2 and 3 different dedicated languages. And so that if there's any, difficulty with understanding, we can also get those interpreters to work with those patients as well. But we are rounding on them. We're looking at vaccination incentives. We're working with public health right now, and we're going to be they have a grant that we're going to tap into to do patient education and patient incentives in real time.
Right. So you said they've been asked 3 times in 1 month, and I would say for folks like that, maybe they should be asked at least a couple of times a week, just to get the word out there.
Yeah. And they're asking, these folks have declined at least 3 times, but they're rounding on all of them. This is, and part of it too is, not only are the nurses doing the rounding, the education, they're also running clinics. And so they're running vaccination clinics 3 times a week, as well as the booster clinics. And so this is what this dedicated cohort of nurses are doing. These are not nurses that are providing care day to day. We pulled out and carved out a separate group because the nurses that are providing the daily care, they're also having to do the asymptomatic testing, testing on day 0, 4, and 8 and 10, as well as asymptomatic surveillance of those patients that are ill. And then of course, managing those patients that have COVID-19 and high risk.
Right. Okay, thank you. That's all the question I have today, Dr. Day. Thanks.
Sure.
Thank you, Dr. Day. And I think that takes us to our last item under item 11. That would be 11H, which is to receive the report relating to federal health policy and the budget landscape. Mr. Santiago, I know that Mr. Margolin can't be with us today. Shall we forego this report, or is there something that some other member of the team would like to share with us before we wrap the meeting?
Well, as Dr. Smith indicated, it's hard to emulate Mr. Bert Margolin, but I did want to let you know something that you all probably already know, the infrastructure bill. Although it did not have direct funding for hospital infrastructure, which was a little bit of a disappointment. We're also concerned that potentially there might be some offsets by reducing some funds to healthcare. There was a particular line there that they were using some of the unspent federal emergency funding to pay for some of the infrastructure. We've been able to confirm that they're actually using some of the funding that was slated for small businesses that hasn't been actually spent to pay for the infrastructure. There is a small item related to DISH funding cuts, but I think the DISH funding cuts that they were speaking to are those for states that are refused to expand Medi-Cal or Medicaid nationally. So I think we avert some of the potential offsets as part of the infrastructure. We would indirectly benefit from some of the investments in transportation and broadbands, given the access issues related to our patients. So at least on that particular piece, we would benefit. So that's pretty much our report, and hopefully Bert will be back next month to give you a full report.
And Mr. Santiago, I was intrigued. It sounded to me like you said that there was some effort underway to reduce DISH payments to states that had not taken up Medi-Cal expansion. Did I get that right?
Yes, like Texas, for example, which is the biggest one.
And presumably that's designed to provide some incentive to move toward Medi-Cal expansion as preferable to a system where payments continue to flow to DISH hospitals, even if they won't take advantage of Medi-Cal?
Correct. And as you know, the
Medicaid, excuse me, in that context.
Yes, and as you know, the Biden administration, as part of the reconciliation bill, which is the next one, is laying a bigger carrot in front of those states to go ahead and expand Medicaid.
All right. Let me see if Supervisor Lee has any questions. All right, then we'll ask for a motion, Supervisor Lee, to simply receive the report on item number 11.
Yes, so moved. On
Thank
item
you.
Number 11, yes.
And I will second the motion. I'll confirm with the clerk that we have no speakers on item number 11.
That is confirmed, sir.
All right, then we'll call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simidian.
Aye.
Thank
Motion carries unanimously. That was the last item on our published agenda, and therefore we are adjourned. I believe our next regular meeting is on Wednesday, December the 15th, and I will see you all then, if not before. Thank you all so much. Take care.
Recording stopped.